Glad to meet you all in this session. I am Dr. Jagadish, Course Director for Biochemistry in Dopamine. So this session, we are going to recall the questions that was asked in FMGE exam in 2025. So we are going to see questions one by one. The first question, which of the following substances at the given concentration makes drinking water unsuitable for consumption as per the safety standards? So if you see the options, option A is fluoride, 0.8 milligram per liter. Option B is cadmium, just 0.3, chloride and nitrate. So this question is to check your understanding on acceptable levels of these minerals in drinking water as per the standards. So if you see the standards, so this table will give you the Indian standards for drinking water. So in this question, fluoride was around 0.8 milligram per liter. Yes, this is correct because acceptable is less than 1 milligram per liter. So this is okay. Cadmium is 0.3 milligram per liter. No, that is not okay because cadmium recommended level is 0.003 milligram per liter. It's a trace element. So that's the correct answer. Chloride 200. Yeah, that's correct because see, up to 250 it is allowed. Then nitrate 20, that's the option. Nitrate up to 45 is allowed. That's it. Okay, fine. One more important point about this is that hardness of the water is mainly because of calcium carbonate, which is allowed from 200 to 600. Okay, so that's about this option. Fine. So the correct answer for this question could be cadmium because cadmium should be present in the concentration of 0.03 milligram per liter, not 0.3 milligram per liter. Okay. Next question. A child presents with abdominal distension and liver is enlarged by 8 centimeter below the costal margin. The liver is smooth on palpation. So which of the following is likely? So abdominal distension, that's the first point. Then liver is enlarged by 8 centimeter below the costal margin. So that is massive hepatomegaly. And the point given is the liver is smooth on palpation. Okay, fine. Now, the point here is a child presenting with abdominal distension and massive hepatomegaly. These are the two important differential diagnoses: glycogen storage disease and lysosomal storage disease. And liver is smooth on palpation. Glycogen storage disease, when the liver is enlarged, it will be smooth on palpation. Viral hepatitis also will be smooth on palpation. Lysosomal storage disease, there will be coexisting splenomegaly. So it is always hepatosplenomegaly in lysosomal storage. Autoimmune hepatitis, which is one of the options listed, can also cause hepatomegaly, but it will not be a massive hepatomegaly. And hepatocellular carcinoma, which is one of the options, will have liver enlargement, but the liver will feel nodular and firm on palpation. So that's about these options. So glycogen storage disease, massive hepatomegaly is possible, and the liver will be smooth on palpation. Lysosomal storage disease, it is hepatomegaly with coexisting splenomegaly, so that is not possible. Hepatocellular carcinoma, the liver will be nodular on palpation. Autoimmune hepatitis, yes, liver will be smooth, but the liver enlargement will not be this much massive as given in this question. So the correct answer for this question is glycogen storage disease. Next question. A 2-month-old infant presents with poor feeding, vomiting, and lethargy. Lab investigation showed hyperammonemia and increased orotic acid in urine. So which of the following is likely to be affected? So all this points towards urea cycle defect. So which enzyme is likely to be deficient in this disorder? Okay. So the clue is ammonia is high, which is characteristic of all urea cycle defects, plus orotic acid is high. So if you see this combination, okay, this points towards type 2 hyperammonemia, which is caused due to deficiency of ornithine transcarbamylase. Okay, so the answer for this question is C. Carbamyl phosphate synthetase deficiency will cause type 1 hyperammonemia, where only ammonia will be elevated. Whereas in ornithine transcarbamylase deficiency, so if this enzyme is deficient, okay, so carbamyl phosphate will accumulate, ammonia will accumulate. This carbamyl phosphate will be diverted to pyrimidine synthesis, which will be broken down to form orotic acid. That is what you see in this patient. Okay, so this is called type 2 hyperammonemia. Okay, and one more important disorder that you should remember is this triple H syndrome, which is hyperornithinemia, hyperammonemia, and homocystinuria. This is caused due to a transporter defect called ORNT1, ornithine transporter 1. If this transporter is defective, ornithine will accumulate. Okay, carbonyl phosphate also will be accumulated because ornithine has to go and combine with carbonyl phosphate. So hyperornithinemia will be there. Ammonia will be accumulated. So hyperammonemia will be there. And this carbamyl phosphate will react with lysine, one of the amino acid, to form homocitrulline. So homocitrulline levels also will be elevated. So this is called triple H syndrome. Okay, so type 1 is CPS1, type 2 is OTC. So this is 1. So this is 2. And this causes triple H syndrome. Okay, fine. So that's about it. Okay, there are other disorders which you can see it from the table. Okay, which are all self-explanatory. So I don't want to explain those things. So this is about this question. So the correct answer is ornithine transcarbamylase. This question, a 6-month-old infant was brought with lethargy, vomiting, and poor feeding. This was developed after prolonged fasting. Lab investigation showed hypoglycemia, low ketone bodies, and mild hepatomegaly. So they also given one more statement. These findings suggest a defect in fat metabolism. So which of the following disorder is more likely? So we have hypoglycemia and hypoketosis or non-ketosis. So it is non-ketotic hypoglycemia. Non-ketotic hypoglycemia, if you see, that is related to fatty acid oxidation disorder. Fatty acid oxidation defect. And there's already a clue, there's a defect in fat metabolism. So among this, which enzyme is involved in fatty acid metabolism, especially fatty acid oxidation? It is medium chain acyl-CoA dehydrogenase. Okay, Her's disease is a glycogen storage disease. Hereditary fructose intolerance is a defect in fructose metabolism. Von Gog's disease, again, it's a glycogen storage disease. In both these diseases, there will be hypoglycemia, but there won't be any non-ketosis. Instead, there will be increased ketosis in this condition. So that's why this is ruled out. Okay, fine. So a few words about this fatty acid oxidation defect. Okay, whenever there is a defect in the fatty acid oxidation, okay, two things will happen. There will be a decrease in ATP and there will be decrease in acetyl-CoA. Both this are very vital for gluconeogenesis. So gluconeogenesis is inhibited and ketogenesis is also inhibited because acetyl-CoA is the one which is converted to ketone bodies. So that's why these patients present with hypoglycemia and non-ketose. That's the explanation. So that's about this. So what are other disorders? Carnitine deficiency, because carnitine is responsible for fatty acid uptake into the mitochondria. So if that is defective, fatty acids cannot enter into mitochondria, so no oxidation. And these are other enzymes: medium chain acyl-CoA, long chain acyl-CoA dehydrogenase, thiolase, and then enoyl-CoA hydratase. So these are the other causes of defect in beta oxidation of fatty acids. This one, a family consumes a diet rich in pulse and rice, and they started developing muscle weakness and some difficulty in movement. So which of the following should be given for prophylaxis? Okay. So whenever you see rice, increased intake of rice, okay, it usually pinpoints towards one vitamin deficiency called thiamine deficiency, especially when you take large amounts of polished rice or milled rice. Because when you polish the rice or when you mill the rice, the outer layer is lost, which is what is rich in thiamine. So when you take a lot of polished rice, there is no thiamine in that rice. So you are more prone to develop thiamine deficiency. So B1 deficiency. B1 deficiency, we already know it can lead to beriberi, which can be dry, which causes neuropathy, which causes can be motor neuropathy or sensory neuropathy, or it can cause wet beriberi, which causes dilated cardiomyopathy. And it can also affect the brainstem, leading to encephalopathy, nystagmus, ataxia, that is a movement problem, and Korsakoff psychosis, which is characterized by a classical symptom called confabulation. So this is more likely in this patient who is taking more amount of rice. One. Okay, fine. So the correct answer could be thiamine. There is one more thing which you should remember here is they have written pulse, but they have not specified what pulse it is. So there's one condition called letharism. Okay, letharism is caused due to excess intake of a pulse called kesari dal, which is also called as grass pea. Okay, so when the diet contains a lot of this kesari dal, okay, which contains a toxin, okay, oxalyl diaminopropionic acid. Okay, this is neurotoxic, which can lead to spastic paraparesis. Okay, so this is a classical manifestation of letharism, which is caused due to increased intake of a pulse called grass pea. So that is also you should remember, which is popularly characterized by two things: one stick stage. Patient walks with one stick, one walking stick. Then it progresses further, and then the patients will start walking with two sticks in their hand. That is letharism. That is because of increased intake of pulse. I am saying this because this question also mentioned about pulse. Okay. A 15-year-old boy presents with the tremors, difficulty in speech, and behavioral problem. On examination, he is having hepatomegaly and golden brown ring at the limbus of cornea, that is Kaiser-Fleischer ring. So whenever you see this Kaiser-Fleischer ring, okay, the diagnosis is straightforward. What is the diagnosis? Diagnosis is Wilson's disease. Which is caused due to a defect in the gene called ATP7B. So now the question here is, which of the following test is best to support the diagnosis? Okay, this is a tricky question. Okay, so when they ask which of the following is best, okay, as per the current literature, okay, you should do first two. There are two first line investigations. One is called serum ceruloplasmin. Okay, second one is called urine copper in 24-hour urine sample. Okay, so these are the two first line investigations. Okay, so in this urine copper has a high positive predictive value. When the urine copper is very high, okay, then that itself is diagnostic of Wilson's disease. So in patients with Wilson's disease, urinary copper will be high, serum ceruloplasmin levels will be low. Among these two, urine copper has a high positive predictive value. So this question is slightly tricky. So I would choose urine copper for this question. When neither serum ceruloplasmin nor urine copper is inconclusive, they are neither elevated or serum ceruloplasmin is neither decreased. But the patient is symptomatic. Only then I should go for liver biopsy for copper estimation. So that's what recent literature says. So if you keep that in mind, then liver biopsy is not the best investigation. Okay, because urine copper itself will help you to identify most of the cases of Wilson's disease. So this is slightly a tricky question. Fine. So this is the combination. Urine copper will be high, ceruloplasmin will be low. Liver biopsy is done only when urine copper and ceruloplasmin is not giving you any answer. Okay. Then you take a liver biopsy, then you estimate copper content in that liver. If it is more than 250 microgram per gram of liver, then it is a diagnostic of Wilson's disease. Then again, you have to confirm this with genetic analysis. You should look for mutations in ATP7B. That's it. Otherwise, urine copper itself will help you to confirm the diagnosis of Wilson's disease. That's about it. Okay, fine. So here, the next question. In a village of Assam, a man is observed walking with the help of a stick and has genu valgum. So what you see here is the genu valgum. Okay, it's also called as knock-knee deformity. Similar symptoms were also observed in many villages. So this problem is there in most of the people. So what is the probable cause of this condition? So the point here is Assam. Then it is not a single man's problem. It is a problem of a village. So Assam is endemic. Assam is endemic for a condition called fluorosis, skeletal fluorosis, which usually happens when the drinking water contains fluoride more than 1 milligram per liter. Going back to the first question, okay. So it usually happens when the drinking water contains fluoride more than 1 milligram per liter. That can cause fluorosis. This can affect dental, causing dental fluorosis, or this can affect the bones, causing skeletal fluorosis. So this the most common, the correct answer will be for skeletal fluorosis. So see here, dental fluorosis is characterized by caries and mottling of enamel. So what you see here is the mottling. And this is the area in Assam which is hotspot for fluorosis, Anglong district of Assam. So as I told you earlier, fluoride content is more than 1 milligram per liter. That if it's there, then it can lead to fluorosis. So how do you manage this? You have to change the source of water, one. Second, or you can tell them to drink the surface running water, which is less in fluoride content. Or you can do something called defluorination of water by subjecting the water to treat it with alum and lime. And this technique is called Nalgonda technique. This will decrease the fluoride content in the water. So these are the various ways to decrease the fluoride content in the water. So this case is more likely to be skeletal. A child has been brought with abdominal pain, irritability, and developmental delay. On examination, the child has pallor, the child is anemic, and there is a bluish line on the gum. Lab investigation showed microcytic anemia, and peripheral smear shows blood cells with basophilic stippling. Okay, so there are clues here. Three clues. One, anemia. Second, bluish line on the gums. Third, RBCs have basophilic stippling. So if you see this, okay, these three, this points towards one thing called lead poisoning. Lead poisoning. Okay. So this bluish line in the gums is also called as Burton's line. Okay. So lead poisoning is fatal because it inhibits various enzymes. For example, it inhibits enzymes of heme synthesis, especially ferrochelatase and aldehyde. So heme synthesis is inhibited. So less heme, less hemoglobin. So there will be microcytic hypochromic anemia. One. Okay, fine. Then apart from this, it can also cause abdominal pain because it can cause porphyria-like symptoms, because any defect in heme synthesis can cause porphyria-like symptoms. Then neuropsychiatric symptoms, musculoskeletal symptoms. Okay. Then apart from these two enzymes, also inhibit this enzyme called pyrimidine 5' nucleotidase. When this enzyme is inhibited, okay, RNA will get degraded. And this can start depositing in the RBC, leading to a characteristic basophilic stippling. That is what you see here. See here, this dots. This is called basophilic stippling, caused due to the effect of lead on an enzyme called pyrimidine 5' nucleotidase 1. And this is what I told you, bluish gum, bluish lines in the gum, Burton's line. This is caused because lead will react with sulfur released by bacteria in the oral mucosa and forms lead sulfide, which gets deposited and forms a bluish line. Okay, so that's the reason for this bluish line in patients with lead poisoning. That's it. Okay, so that's about this question. So the answer for this question is lead poisoning. Okay, fine. Now the next question. A 7-year-old child has been brought with fatigue and poor concentration. Mother reports the child has been eating things like chalk and soil for the past few months. Okay. The peripheral smear shows microcytic hypochromic anemia, which is usually seen in, okay, which of the following is most likely diagnosis? Okay. So microcytic hypochromic anemia is commonly seen in iron deficiency anemia. That is one straightforward clue. The other clue is this: child is indulged in eating non-food items like chalk and soil. What is this condition called? This condition is called pica. So pica is also a risk factor for iron deficiency anemia. So the answer for this is iron deficiency. So pica is the intense craving for eating non-food items such as clay, dirt, soil, chalk powder, soap, cardboard, or even raw rice. Okay. So that's about this case. Okay. So this is a clear-cut case of iron deficiency anemia. The cause is pica. Okay. Fine. So which of the following is an essential intracellular antioxidant that aids in scavenging reactive oxygen species? This question is also a tricky question because when it comes to antioxidants, there are two types. Okay, one is enzymatic antioxidants, the other one is called non-enzymatic antioxidants. Enzymatic antioxidants are those enzymes that are involved in antioxidant defense mechanisms such as superoxide dismutase, catalase, glutathione peroxidase, and reductase. Among these four enzymes, superoxide dismutase is predominantly an extracellular enzyme involved in scavenging the free radicals. Other three enzymes are intracellular antioxidant enzymes. Okay, clear. Then it comes to non-enzymatic antioxidants. Glutathione is the most essential intracellular antioxidant. Okay, vitamin E is also an antioxidant. Vitamin C is also an antioxidant, but they mainly act by preventing lipid peroxidation of biological membranes. Okay, they are not strictly intracellular. Okay, then alpha lipoic acid, intra and extra, both it has an intra antioxidant property as well as extracellular antioxidant property. So glutathione is an essential intracellular antioxidant. Okay, fine. So answer for this question is glutathione. Okay, superoxide dismutase is predominantly extracellular. Okay, ascorbic acid and tocopherol is predominantly membrane lipid peroxidation preventing antioxidant. That's about this question. This is a slightly difficult question. Next question. A 17-year-old tall male presents for routine checkup. He has long limbs, arachnodactyly, hypermobile joints, high arched palate, okay, then high arm span. Genetic analysis showed mutations in fibrillin 1 gene. It's a straightforward question. This is a case of Marfan syndrome. Clue is all these features plus fibrillin 1 gene mutation. That's it. So this is a case of Marfan syndrome. Ehlers-Danlos syndrome, it's caused due to collagen 5A1 or collagen 5A2. Okay. Oncogenic osteomalacia, that's caused due to fibroblast growth factor 23 mutation. So that's about this question. Okay, fine. So this is how Marfan syndrome will look like. Okay, one important point about this is these features can also be seen in a condition called homocystinemia. That's why they say patients with homocystinemia presents with morphanoid features. Okay, fine. Next, a patient presents with fatigue, hepatomegaly, and anemia. Hemoglobin electrophoresis show presence of HPS. What will be the treatment? So the question is, what's the treatment for sickle cell anemia? Sickle cell anemia can be treated by multiple modalities. Okay, but one thing which you should keep in mind is first mode of treatment would be to give hydroxyurea in an attempt to increase HbF, hemoglobin F, that is fetal hemoglobin. This will prevent sickling. And because hemoglobin F has a high affinity towards oxygen. Okay, so giving hydroxyurea will increase the levels of HbF. So that's the first important mode of treating HP, sickle cell. Then you can attempt blood transfusion, but only in severe cases of anemia. The best option should be to try exchange transfusion. What is exchange transfusion? Take blood from the patient, remove some blood from the patient, and then you give fresh blood so that you can dilute the pre-existing hemoglobin S in the circulation. Then there are other three important drugs called glutamine. Glutamine is also known to reduce sickling, and glutamine is also known to reduce oxidative stress. Then there are one monoclonal antibody which is given to treat sickle cell. That is called crizanlizumab. It's a monoclonal antibody against this protein called P-selectin, so that this will prevent the adhesion of RBCs to the endothelial cells, so that the sickling crisis can be avoided. Okay. Then there's something called voxelotor, is a HBS polymerization inhibitor. Then you have to give analgesics to treat painful crisis. That's it. Okay, so that's about this. So hydroxyurea is the best mode of treatment, followed by blood transfusion, but only in severe cases. Then this monoclonal antibodies and L-glutamine, but iron supplementation should not be attempted because sickle cell patients are always at risk of iron overload. So if you give iron supplementation, that is going to aggravate iron overload further. So it's always better to avoid iron supplementation in sickle cell disease patient. So the answer for this will be hydroxyurea. Iron infusion contraindicated. Blood transfusion only in severe cases. Only in severe cases. Beta supplementation not at all related to this condition. Okay, fine. So that's about this. Which color-coded collection tube is useful for coagulation studies? Okay, so that is mainly to check your knowledge on what tube you will use to check for PT, APTT, and PTIN or so and so. Okay, so the correct answer for this question is blue, because lavender is a EDTA tube. See here, blue is a sodium citrate tube. Sodium citrate will be the preservative in that tube. Okay, that is mainly used for coagulation studies. Then there's something called serum tube, which is a red color tube. It's mainly done for collecting or doing tests in the serum. For example, serum urea, serum creatinine, lipid profile. Okay. Then liver function test, renal function test. Everything can be done only when you collect samples in the red color tube. And there's a counterpart for this tube that's called yellow tube, which is a serum separator tube, which can also be used to collect blood sample where serum is needed. Then followed by green. Green is a lithium heparin tube. Okay, it is used for some special tests in biochemistry. Okay, not for all the tests, only for few tests. For example, homocysteine. You want to measure homocysteine, you should use green color tube. Then lavender tube, EDTA tubes, which can be used for CBC. Then the gray tube, okay, which is the tube exclusively used for glucose because it contains a glycolytic inhibitor called fluoride. So this is the tube you should use for glucose estimation. That's it. Fine. So this question's answer will be blue because that is what is used for coagulation studies. Fine. Which vitamin deficiency leads to lactic acidosis? Okay. This is a straightforward question. Okay. Pyruvate is converted to and this pyruvate is also converted to acetyl-CoA. For this, you need pyruvate dehydrogenase. For this, you need lactate dehydrogenase. This pyruvate dehydrogenase is a thiamine-dependent enzyme. So when thiamine is deficient, so this reaction will not happen. So what happens? Pyruvate will accumulate, which will be converted to lactate. So that leads to lactic acidosis. So the thiamine deficiency leads to lactic acidosis. Niacin deficiency, no, that leads to pellagra. Biotin, mainly the carboxylation reactions are affected. Whenever you think of biotin, you think of egg, avidin. Excess intake of raw eggs can lead to biotin deficiency. Riboflavin, no. That can cause glossitis, okay, magenta colored tongue, conjunctivitis, so and so. So answer for this question is thiamine. A man presents with high chylomicrons with eruptive xanthomas and lipoprotein lipase activity was low. Chylomicrons are high, lipoprotein lipase is low. The answer is straightforward. Familial chylomicronemia syndrome, which is caused due to defect in LPL enzyme or ApoC2 defect. Okay, so that's about this question. It's a straightforward question. And one more clue is eruptive xanthoma. Next option will be familial dis-beta lipoprenate. This is type 3 lipoprotein disorder where there will be accumulation of remnants of chylomicron and remnants of VLDL. Why this happens? That's because of a ApoE defect. Okay, fine. Familial hypercholesterolemia, this is type 2A. That is caused due to LDL receptor defect where cholesterol levels will be high. LDL cholesterol levels will be very, very high. This can be caused due to LDL receptor defect, ApoB defect, or rarely by this protein called PCSK9 defect. Familial hypertriglyceridemia, there will be accumulation of triacyl VLDL. There will be accumulation of chylomicrons, so there will be accumulation of triglycerides. So for this, there is no genetic defect known for this condition. Okay. So here in familial hypercholesterolemia can also cause xanthomas, that is usually tendon xanthoma. Type 3 can cause palmar xanthoma. So that's about these conditions. Okay, fine. So this table will give you the whole thing. Okay. So type 1, this is what this case is about. It's like LPL, lipoprotein lipase deficiency causing accumulation of chylomicrons, leading to eruptive xanthomas. That's it. A patient presents with multiple colonic polyps and has been diagnosed with a cancer called hereditary non-polyposis colon cancer. Which DNA repair mechanism is most likely defective in this condition? Very commonly asked question, straightforward. Mismatch repair mechanism. That's it. Because this nucleotide excision repair causes xeroderma pigmentosa. Then basal cell carcinoma. Base excision can cause spinocerebellar ataxia. Double-strand DNA break repair can be rectified by either homologous enjoining or non-homologous enjoining. If homologous enjoining is defective, it leads to ataxia telangiectasia and Bloom syndrome. Non-homologous enjoining leads to severe combined immunodeficiency. So that's about this repair mechanisms, and when these repair mechanisms are defective, and these are the disorders. So that's about this question. So which of the following mutations is causative of familial amyotrophic lateral sclerosis? Okay, the option is defect in or mutation in this gene called SOD1, which stands for superoxide dismutase, which is an intracellular antioxidant enzyme. Okay, fine. So that's about this. FMR1 can cause fragile X syndrome. CFTR leads to cystic fibrosis. HTT leads to Huntington's disease. Okay, fine. This too, it's a trinucleotide repeat disorder. Okay, fine. So that's about this question. So the answer for this is SOD1. Okay, thank you.